Yes, I'm Federico Cappuzzo. I'm the Director of Medical Oncology at the National Cancer Institute Regina Elena in Rome, Italy. I just recapitulated the data that were presented yesterday at this meeting, the data with immunotherapy. So I display data from 4 different clinical trials, one considering the addition of an anti-angiogenic agent to chemoimmunotherapy. And this trial was a completely negative trial showing no benefit by the addition of biosimilar of bevacizumab to chemoimmunotherapy. A second trial was exploring the role of PARP inhibitors in combination with immunotherapy, again in patients with metastatic non-small cell lung cancer. And although this approach is supported by preclinical data, no evidence of benefit was observed in the trial. Even in terms of overall survival, we cannot exclude a detrimental effect of this treatment. The other 2 trials were one in patients with brain metastasis. The authors evaluated the addition of ipilimumab, nivolumab, and chemotherapy in patients with asymptomatic or oligosymptomatic brain mets. And again, this trial didn't meet the primary endpoint. So the disease control rate at 6 months, that was the primary endpoint of the study, was not met. And finally, French investigators evaluated the addition of atezolizumab to chemotherapy in the elderly population. That is a group of patients very well represented in our daily clinical practice. And the study didn't, again, meet the primary endpoint of overall survival, but all the other endpoints, response rate, progression-free survival, disease control rate, were certainly in favor of the addition of immunotherapy. So that was probably the major abstract presented yesterday only for immunotherapy. Well, the IMSHIN 002 trial explored the possibility of giving atezolizumab subcutaneously. Patients gave their preference between subcutaneous and intravenous, and the trial showed clearly that the patient preference is in favor of subcutaneous usage of atezolizumab. Also, this approach gives a lot of advantages for the patient in terms also of timing that they have to spend in the clinic, as well as for the hospital in terms of organization, timing for preparing the drug. So is an approach that is really convenient probably for everybody. So this is the major message. And what is presented at this meeting is an update of these results, confirming with a longer follow-up that in effect all these endpoints were met. I think a combination of ADC and immunotherapy is a very promising approach. Of course, we need the data from large clinical trials to understand exactly what is the role of these agents. At the present, we have some data showing potential efficacy, of course, of this approach. What we hope, of course, is that ADC could be superior to standard chemotherapy. And we know that at the present also we need to pay attention to the toxicity that we can give with this combination. I cannot say that we have studies really changing standard of practice, but we have important studies that were presented. In my opinion, the survival data from the FLAURA2 trial are very relevant because there is a survival benefit by the addition of chemotherapy to osimertinib in EGFR mutant non-small cell lung cancer. This is very important because could in some way impact also clinical practice, doctor and patient preference for the frontline treatment. And the other important data are about ivoneshimab, that is a bispecific anti-PD-1 anti-vascular endothelial growth factor. The data presented yesterday together with chemotherapy in osimertinib-resistant patients are very, very interesting. And this is certainly one of the new options that probably we can offer to this group of patients. Well, the most important point is that even if immunotherapy is completely changing the treatment of non-small cell lung cancer, unfortunately, we still have a consistent proportion of patients relapsing or that are insensitive, so that are with primary resistance. So the real challenge is to increase the number of patients, the percentage of patients sensitive to immunotherapy, and to reduce, of course, the percentage of short short-term responders. So patients in which, even if we obtain a response, the duration of response is short. So we need certainly to improve strategies using, of course, combinations or new immunotherapeutic agents with the endpoint of increasing the percentage of long-term survivors.